So for the last 5 or 6 years at least, I've been focusing my learning on, or my teaching on putting together lectures based on expert differential diagnosis. We find a particular imaging finding or are presented with a patient symptom such as right lower quadrant pain, and I want to help you try to figure out an approach to this that will allow you to provide a specific or a very clinically useful differential diagnosis. Well, we know that the patient probably has an ileus or obstruction or something else accounting for the dilated bowel, but it's not always easy, and our diagnoses are often not correct. So what constitutes dilated? On a plain film, small bowel, 3.5 centimeters or more in diameter, and a less on CT. Now, CT is actually the more accurate measure of the degree of dilation, but many of you learned during residency figures for what constitutes significant dilation that are almost all based on plain film criteria, which can be a real problem. Plain films are magnified. Colon, we usually don't see the transverse colon more than 6 centimeters on a KUB, 5 centimeters on CT. Cecum can be up to 9 centimeters on KUB without being too worrisome, but if you see a cecum that is 9 centimeters in diameter on CT, you'd better be worried about significant dilation and possible ischemia. So we're going to talk about this, especially if the dilation is acute and in the post-op patient, something that was called Ogilvy's syndrome way back when. And you really want to alert the referring physician or surgeon for the possible need for decompression. Every resident that does a fluoro rotation with me gets a 100-point question test that they have to go over with me, and this is one of the test questions. This patient complains of abdominal distension. And what is the finding? Well, we see the feeding tube, and we see excess gas within the bowel, but no bowel segment is particularly dilated. Without dilation, you don't have ileus or obstruction, but this is not a normal bowel gas problem. So my dictation on this is excess gas throughout the large and small bowel without segmental dilation, a pattern indicative of aerophagia. You will see this in at least 80% of patients who have feeding tubes in place. They are symptomatic with this, they are uncomfortable, and this is not a normal bowel gas pattern. Every resident, when confronted with this the first time on the rotation, misses it. They look at this, they see the feeding tube, and they say, I see small bowel dilation, I don't recognize any colonic dilation, paragraph impression, small bowel obstruction. And I say, well, no. You note that the patient's had recent liver transplant. This is actually dilated colon up here. This is dilated colon. And they say, but I don't see any gas in the ascending or descending colon. That's true. They never recognized the ascites on this until taught the criteria for diagnosing this. And this is the typical appearance for ileus